Sir, we are live.
Right. Karosh.
Maninder ji, little bit network issue is there. You need to manage.
Sham, start kar lo.
Sure, sir. Sure.
एक मिनट। Hello, good morning. My voice is audible?
Yeah. Everything is fine. Please continue.
Hello, good morning to you all. Very warm welcome on behalf of Indian Academy Pediatric Delhi State Branch. I would like to warm welcome to our speaker, Dr. Rajeshwari, our chairpersons, our immediate past president, Dr. Basavaraja sir, and my colleague, Dr. Juma Shankar. And I would like to thanks to Dr. Maninder to taking the all plan to make this program successful. Over to my president.
Good morning, everybody. I'm Dr. Pankaj Garg, IIP Delhi President for this year. I extend my heartiest welcome to all the people, all the panelists, especially Dr. Basavaraja sir, our past President IIP, and a very senior intensivist, Dr. Juma Shankar, and Dr. Rajeshwari, who will be the speaker for the day. Not to mention Dr. Maninder, who is the key person who has been working very hard to make this module successful. Dr. Sham Meena, my colleague, my secretary, Dr. Ajay, Dr. Dinesh Goyal, and Sushil, and everybody else who is there on the platform. Delhi IIP has been doing this e-master class in various specialties. We have done it in past in pediatric hematology, neonatology, rheumatology, endocrinology, cardiology, and now we are doing pediatric intensive care. Pediatric intensive care is a very essential part of every student's as well as office-based pediatrician's perspective, because we know that babies have a very small margin. They can get sicker anytime, and we should know what is happening in the field of pediatric intensive care. We should be able to manage them initially. We should also know when we should be able to refer them to a specialist. So with these words, happy learning. We'll keep on enjoying these sessions. Live sessions are always good because you can discuss with the seniors, with the colleagues, and all questions are answered, though the recording will also be available later on. So I'll request Dr. Maninder to start the proceedings now. Over to Dr. Maninder.
Good morning, everyone. Thank you, sir, for giving us a platform for carrying out this essential activity. Before moving forward, I'd like to introduce the moderators first. We have our esteemed President, IIP, Dr. Basavaraja sir, who has not only led the pediatrics, but he has special interest in pediatric intensive care. He is also a professor of pediatrics in Bangalore, one of the largest pediatric ICUs of the country. He's managing with his team, and he has brought out many guidelines in pediatrics as well as pediatric ICU. So fluids and vasoactive is a very complicated topic, though it looks very simple. People have developed their own formulas that first I start that and that, but it is really complex, and how to make it simple. It's a pleasure to have you here with us as a moderator. And the second moderator and the expert is Dr. Juma Shankar. She's a colleague, she's a friend. We started intensive care journey almost together. And she has brought out the landmark papers in fluid therapy, in sepsis and shock, which are quoted worldwide in all guidelines. It's a pleasure to have Dr. Juma Shankar with us in this esteemed gathering of panelists and experts. And then as a speaker, we have Dr. Rajeshwari from Apollo Chennai. She again is one of the experts in pediatric sepsis. She and her team have come out with many landmark studies in pediatric sepsis, and they are a part of many international guidelines also. So we have the best of the best with us. And with that, I would request Dr. Rajeshwari to start the session with a few words from Basavaraja sir first.
Yeah, thank you very much, Dr. Maninder, Dr. Juma, Dr. Rajeshwari, Pankaj, Dr. Sham Meenaji, Ajay Gupta, and all the delegates. The delegates is Lalit Mendireta and all. So
Yes,
I know Delhi is always known for quality academics. IIP Delhi, which has been doing great work. So I'm closely involved in academic activities of IIP Delhi State Branch, especially COVID time also. They came out with a lot of academic activities through the e-webinars and all. And today's session is a very, very relevant, not only to the intensivist and emergency physician, even for an pediatricians, optimization of a fluid and vasoactive agents in the clinical practice is the need of the hour. I'm sure Rajeshwari, who has been very done a pioneering work along with Dr. Juma, this session is going to be very, very useful to all the delegates who has been attended. Maninder is leading from the point. Maninder, any job you give it to Maninder, you'll make it more interesting. Not only very interesting, you'll make it a happy learning. That's the beauty of our Maninderji. Thank you, Maninder, for coming out with a lot of creativity in it.
Thank you, sir. Thank you. I request Dr. Rajeshwari to please start.
Hello, can you hear me, Maninder?
You have to play the slides again. Share the slides again.
Can you see my slides?
Yes.
Yes, sir.
Okay.
Perfect.
Okay.
Fine.
At the outset, I would like to thank our team IAP Delhi and Dr. Maninder for giving me this opportunity to talk on this topic, sepsis management of septic shock in children. Okay, I'll try to keep it as simple as possible since I heard there are a lot of pediatricians here and very few or hardly any intensivists. In case any doubt, I think you can share on the chat box. We can discuss towards the end of the session. Okay, so the outline of my talk today would be on how to recognize septic shock early, which is a key in any management of any disease, precisely in septic shock. And how do you resuscitate with fluids? And what kind of inotropes do I choose in my child? And how do you monitor these children? So the preamble of my talk will be on these four topics. It's hard to cover the entire septic shock in 45 minutes. So I will try as much as possible with some explanation. Hopefully you can understand by the end of this talk. So everyone has their own sepsis screening tool in your own hospital. So I think whatever suits your hospital best, you should have one. Mainly everyone should be familiar with early recognition tools, which is very important. It can be displayed in your OP or clinic or emergency or wards or wherever it is, so that the beginners can quickly recognize shock. So as you're all aware, septic shock will have various manifestations, clinical manifestations. The important ones are mentioned here. Temperature, which is very important. We all know hyperthermia or a febrile episode is important, more than 38 or 38 degrees centigrade. Of course, I would like to reiterate here that hypothermia is much more important, much more in infants. So never ignore hypothermia. It can be a red flag in children, especially infants. Next comes the heart rate. So you have varied spectrum of heart rate in children, right from neonates or 1 month of age up to 18 years. So I think it's very hard, but with time you can remember and at least you can guess, okay, this child is tachycardic or not. So you can have, that's the reason we need some kind of reckoner like this to display so that you can recognize these children quite early. And next important thing with circulation is the blood pressures. So again, it's important to have an appropriate size blood pressure cuff to measure which arm you measure, how is it, the size, and for the age of that child is important. And of course, there are again various values. I think the rough estimate is like for any child, an infant, it should be less than 60 is abnormal, which is 5th centile, and between 1 to 2, and beyond that, it will be like between 1 to 2 years, it will be 70 plus age into 2, and for any child more than 7 or 8 years, it's 90 is the cutoff. So I think this is something which is very important to recognize the blood pressure. What is the cutoff? The 5th centile. Below this, a patient is hypotensive. Next comes the respiratory rate, which is again age dependent, where there are several values. We can just a clinical gestalt will we can predict whether child is tachypneic or not. You need not have these absolute numbers, but yeah, with the tachypnea, with retractions, all these, the child is, there is some compromise in this patient. Next comes the capillary refill time. So this is very important parameter which you have to monitor in child. So this has to be done in a specific way. It's hard for me to explain how to do. There is, I think there's a video released by Andromeda, where you can access that and see how it has to be done exactly. You need a glass slide, which we use in the physiology lab, or you can do with your bare hands as well. So there's a way technique of doing that, and any value less than or more than 3 seconds is abnormal. So you need to be cautious. You may need to be alerted in these patients where the capillary fill is more than 3 seconds. Next important thing is a mental status. So most of the children are happy, they're quite stable. If they're confused, irritable, or inappropriately crying, then there's some problem with this child. Most of the times it could be in the scenario of fever, it could be hypoperfusion, that is a decreased blood perfusion to the brain. So these are next important one is the pulse volume. So you all know how to check the pulse volume. You should specifically check for the lower limb pulses and the upper limb pulses. The lower limb ones are the ones to be lost first. Whether it is feeble, it is normal, or is it bounding. So subsequent slides, I'll tell you how various shocks manifest. The changes in pulse pressure will manifestation of your underlying physiological condition. Next, after looking at the pulse, you'll have to look at the skin color. Is it child is mottled? Is he pink or not? And how the peripheral perfusion is along with that. So these are some of the clinical, components in examination where you can pick up a child who is in shock or who is sick. Other important thing to remember is the high risk conditions, like especially a child who recently had a surgery, who has underlying malignancy, or who has invasive lines or catheters, and of course, immunodeficient child. So when you have any of these conditions, you'll have to have a lower threshold for early recognition and treatment. So some of the red flags, I think I already told some of these. The one important one is hyperthermia or hypothermia. So hypothermia is much more important. You'll have to alert your So you have to alert your seniors, or even if you can recognize and quickly start treatment. The next is tachypnea. And of course, one question I want to ask, how many of a patient is tachycardic and has temperature as well? So would you consider the tachycardia as a part of temperature and ignore the heart rate? Say a 2-year-old child has a heart rate of 160. So, and the temperature is 38.5. Child is febrile. So most of the times we know that everyone says that, this child has fever. So that's the reason heart rate is high. Will you accept that?
No,
Normal heart rate?
it's very high for the temperature.
Exactly. So what I want to reiterate here is the tachycardia is, it's not always related to temperature. For every 10-degree rise in temperature, for every 1-degree rise in temperature, the heart rate will increase by only 10. So you need to be extremely cautious in interpreting the high heart rate to temperature. Okay, so it's very important to rule out the sepsis before you say it is related to just temperature. Of course, you should have, as I described earlier, the prolonged capillary fill time, child is irritable or drowsy. So these are some of the signs where you'll have to be extremely cautious in initiating early therapy. So the sepsis 6, you'll have to get first immediately after recognition, oxygen has to be administered. But I think after the new recent PSU oxy trial, you need not give oxygen in all patients. Only in those with less than 90, you'll have to administer oxygen. Immediately get an IV access and draw blood cultures and the point of care blood investigations. And you can start IV fluids and inotropes, whatever is required in that child. So what are the red flags and what do you do initially when you recognize? You'll have to give oxygen, as I said earlier, if SATs are very low. Otherwise, there's no need to give default for all children. You can give initial fluid bolus of 10 or max of 20 per kilo of any fluid, maybe NS or finger lactate or saline. And I would like to say here the choice of fluid doesn't make a big difference here. Maybe in subsequent slides, you'll know why it doesn't make a big difference. I think a bolus of whatever is available with you, any crystalloid should do. And inotropes and pressors if the blood pressures are low. And of course, you'll have to give a antibiotic, first dose of antibiotic based on your where the focus is. And of course, what do you take from the patient? You take 2 sets of blood cultures and other sites of infection wherever your focus of your suspicious of infection, like it could be a urine or a lung BAL sample or something. Wherever the focus is, you need to take sample from that area. And if there is a septicemia, clinical suspicious of multi-system involvement, of course, blood culture is important. And as I said earlier, the point of care tests like blood gas and lactates, all those are important. And I think important one is here, the simple thing is urine catheters to monitor the output. So I think most important of all these I would consider is your basic clinical examination. You can pick up a lot of things, early recognition, red flag the child, and do the things whatever is required immediately. So what is the choice of antibiotic when you immediately recognize and you've taken the blood samples and you're trying to start IV fluids? What choice of antibiotic would you give here in this child? So as I said previously, it depends, it depends on the focus of infection. Suppose you have a child with pneumonia. Let's say he has tachypnea, crepitations and tachypnea distress, all those. So the choice differs. If it is meningitis, you need a drug which penetrates the CNS. And soft tissue infection, you need something which covers MR, like a gram-positive and gram-negative infection. Another important thing is important to know, is the patient in hypotensive shock or no? So choice will again differ. You need a very broad spectrum antibiotics like gram-negative and gram-positive cover if the patient is in shock or organ failure. And again, next important thing you should ask before starting is it hospital acquired or is it community acquired? Hospital acquired are not really that, community acquired are not really that resistant. Of course, if you have community hospital acquired, you need to have a broader spectrum coverage, which includes gram-negative and of course gram-positive. And high-risk conditions like immune-compromised or pre-morbid or previous surgery or recent surgery, you need to have high-end spectrum of antibiotics.
Antibiotics.
So again, these are the conditions you'll have to look at these before you initiate the antibiotic. So one question I would ask at this point is, a child has pneumonia who is just tachypnic distressed, who has saturations around 90%, is febrile, is irritable. And there's another child who has tachycardia, poor pulses, has hypotension. So which of these two would be more sick? So definitely the child with hypotension is more sick. So whenever you find a child with pneumonia, you should look, is it a single organ or there is remote organ failure? So if it is single organ, especially lungs, the choice of antibiotic will differ and your aggressive, the vigor which you to treat will again differ. So bacterial pneumonia with no organ failure, your choice of antibiotic can be simple. If it is community acquired, a simple augmentin or with or without macrolide. And if you have a child with pneumonia who has shock and remote organ presentation, then your choice differs where you need BL, BLI, and of course, and sometimes MRSA cover as well. So it's very important you know what's your focus of infection, what could be the potential organism and the antibiotics for that, so that you win half the battle if you treat appropriately here. Then the important thing is look for inadequate source control. So there may be an abscess lying in the abdomen somewhere, or it may be a cellulitis where you may be missing. So I think it's important, much more important than fluids and inotropes, if you have adequately looked at focus or source and then address that. So look for the inadequate source control if the shock is not improving. So having covered to recognize early and how to do initial 10-15 minutes, let's see next what fluids we give, how do you manage? So we all know in septic shock, it's a very complex physiology. It's not just, a cardiac dysfunction or, hypotension. It could be several reasons. So if you go in a structured way, it can be decrease in preload. It can be problem with the contractility, or it can be with the vascular tone. So we'll have to look at all these three factors before we initiate treatment. So let's look at the preload. So initially, as I told you, when a patient presents in shock, when you have prolonged capillary refill, tachycardia, and with or without hypotension, you can try a fluid bolus. So 10 to 20 or 10 to max 20 per kilo shouldn't be a big problem unless you're suspicious of cardiogenic to begin with. So how do you differentiate a patient who presents in shock has cardiac dysfunction or it's just septic shock? So it's very hard here to determine what it is, but maybe some clinical cues can be there. Suppose if the patient is tachycardic, very, very high, say like an infant 1 year, has a heart rate of 200. Okay, he has cold peripheries, prolonged CFT, very tachypneic, a big liver. So you're suspicious more of myocarditis or cardiogenic shock in this child, okay, than septic shock. However, we can't rule out at that point of time. So if you don't have any tool, I think the clinical examination itself will give you a cue. So suppose if the patient has a very narrow pulse pressure, that means, this patient has cardiogenic shock. There's no stroke output volume, cardiac output at all. So the patient may have myocarditis. So that's the reason I've been telling you time and again that don't give too much fluid bolus in child, even with septic shock. Just give 10 to 20 per kilo and see the response. What's happening to my child while I'm giving fluids? Is the tachypnea worsening? Is the distress worsening? SATs falling or heart rate worsening? So if you find any of these, you have to think, you have to allude more towards cardiogenic or myocardial involvement than pure septic shock. So again, pure septic shock, you can't say because there can be element of myocardial dysfunction. What I'm trying to say here is a patient may have myocarditis. So be extremely cautious when you're giving even the first 10 or 20 ml per kilo. Watch for all these signs. Just don't give fluid bolus and go away to look at the other patient, especially if they have hypotension, because you may be filling up, pushing the heart too much if they have cardiogenic shock or myocarditis. So give a bolus and see the response, what is happening. If you have a tool, you can obviously look at echo and see how the contractility is. But if you don't have in your unit or access or how to do, then I suppose you can do go by your clinical examination. So after the back to septic shock, should I give fluids? Yes, you can give 10 per kilo or max 20 per kilo. When should you not give? What are you target and when do you stop is something what I'm going to cover now. So septic shock, everyone thinks it's hypovolemia. We need to give lots of bolus. The recommendation says in low income countries, you can give up to 40. In high income, you can give up to 60. It's not so, because all in septic shock, there is a relative hypovolemia. So the physiology is completely different here, unlike in pure fluid losing states like diarrhea, dehydration, or even to some extent dengue. So there is a massive capillary leak in dengue. You have hypotension where they may need lot of fluids. Whereas in diarrhea, dehydration, there is obviously fluid losing states. You can give fluid. So the presence of tachycardia, hypoperfusion, decreased urine output, and acidosis, if you see, are all same in all spectrum of cases, right from dengue to diarrhea, dehydration to septic shock. So it's not that simple as Maninder said initially that, the presence of shock is septic. Presence of shock doesn't mean always septic shock. It could be anything. So your clinical examination and your history, of course, is very important to try to dissect and see what my patient has. So coming to septic shock, they have hypovolemia. The major physiological problem is vasodilatation, and of course, they can have myocardial dysfunction as well. So it's not as simple as that patient is in shock, let me give some fluids, like in diarrhea. So you need to figure out what to do after giving first 10 ml per kilo or maximum 20 ml per kilo. So why is it important fluid therapy in septic shock? As I said earlier, hypovolemia is relative and it's not common, unlike in other condition. There is no major capillary leak like in dengue. So there is fluid is important, but not as important as in other condition. So several studies have shown that fluid therapy resulted in a transient improvement in cardiac output Okay, and it lasted for less than 1 hour. So in 45 to 60 minutes, the effect of fluid is waned off. So there should be other methods to support your circulation if it is not fluid. So consequences, if you keep giving more and more fluids in these patients, it will be hard to reverse them, because you don't need more fluids, because there is vasodilatation component which is much more than your hypovolemia. So fluid is accumulated in the wrong places, and if you keep giving more and more fluids, it keeps on accumulating, and you have need for ventilation, you need more and more inotropes, your heart may swell up more and more, and of course they may go into organ failure requiring dialysis and so on and so forth. So there is a clear literature in adults, but what is the evidence that not much fluid is required in pediatric septic shock? This is what we studied in our unit 2 years ago, and which was published in PCCM and CCM both. So we found that the fluid bolus after the initial 10 to 20 ml per kilo, we found that the cardiac output and blood pressure improved only in 1/4 of children. And we found there was no association with the blood pressure and the cardiac output. And most of the children required high pressors. More than 50% of the children required pressors. So all children who presented to ICU or emergency who received 10 per kilo, after the first 10 per kilo, we gave fluid bolus, another 10 per kilo, and we studied these things. What happened to the MAP, what happened to the cardiac index using cardiac output monitoring. And we found that in these children, the cardiac output improved in 31%. The cardiac output did not improve in 70%. So that means these patients are dangerous. If you give more fluid in them, they can worsen. So, and further, in those patients who not only did not improve cardiac output, their MAP fell, the blood pressure fell in 48%, on of which the mortality was also high 5. So even those patients who had improvement in cardiac output, the blood pressure did not improve in 14%, and the mortality was again higher. What I'm trying to say from this is, when you give a fluid bolus, not all patients will respond in terms of shock. If you don't have cardiac output monitoring, it's very hard to say clinically what's happening. You can at the most say, is my pulse pressure improving? Okay, that may, or my CFT is improving, or urine is improving. Because clinically, if you don't have cardiac, that's all you can do at the bedside. For the MAP, of course, you can look at the blood pressure and see what's happening to the blood pressure. When I'm giving fluids, is the patient improving in terms of heart rate, blood pressure, or pulse pressure, CFT? And on the other hand, what's happening to the BP? If it is not improving, please stop fluids. It may worsen BP and may cause more hypotension. So why does fluid cause hypotension in some patients, as we saw? So lower MAP is secondary to vasodilatation. As I said earlier, fluid, when you give fluid, there can be vasodilatation simply because there is endoglycocalyx damage. More and more fluids can cause vasodilatation, and that's the reason we saw hypotension in our patients. What does hypotension cause? It decreases the perfusion pressure to the organs and further worsen organ functions, and when it can cause organ failure. So fall in perfusion pressure can worsen the organ perfusion, including the coronary perfusion, and it can cause a myocardial edema and myocardial hypoperfusion and ischemia. So how do we decode at the bedside? So clues from, as I said earlier, see for the clues after giving a fluid bolus, right from the beginning, from the history, from the clinical examination, and during the process of fluid bolus, what's happening to the patient. Is my cardiac output improving? Yes, you can continue fluid boluses. Is my MAP improving? Yes, you can give. So keep monitoring these things at least 5 to 10 minutes during your ongoing fluid bolus. And the third important thing I want to tell is a patient intolerant? While you're giving fluid bolus, the patient has more tachycardia, more tachypnea. You can know that patient has intolerance. It may be cardiac dysfunction worsening. So that's the point you have to stop the fluid. So if the MAP falls or the fluid tolerance occurs, you have to consider immediate inotrope therapy and stop your fluid bolus. So remember, fluids can be both beneficial and detrimental. It can improve cardiac output on the blood pressure in some patients, but not in all. So you need to be very careful in whom you have to continue and in home, you shouldn't. The effect may be sustained only in a few. And as I said, even if you give a fluid bolus, the effect may last for not more than an hour. Fluid can vasodilate and decrease the blood pressure and decrease the vascular tone. It can worsen the cardiac function, both systolic and diastolic. It can increase capillary leak by damaging the glycocalyx. So you'll have to be extremely cautious while you're giving fluids beyond 10 to 20 ml per kilo. So we need to reframe the question in any patient. Whether a patient is fluid responsive rather than whether they need fluids. So that's something more we'll have to look for before we consider fluid bolus. Remember, every patient can be fluid responsive, even they are intolerant. So that's why it's a very, very, very complex topic, fluid responsiveness. Simply, most of the patients don't need fluid. You can start early inotrope. And during the course, you have find that there is some fluid responsiveness, which is little hard for me to cover entirely in this 45 minutes. If you find that patient is fluid responsive, you can try, but again, watch for fluid intolerance during the process of fluid, during the course of fluid bolus. So before giving a fluid, ask your patient, is it really indicated? Is there ongoing loss? Yes, you can give. Whether fluid can be tolerated or not. Is my patient safe for fluids? You have to look for that. And the third important thing is, if you find a distended IVC, if you have an echo machine, please don't give fluids. It indicates congestion. You may have to give other therapies for these patients. So always you look for fluid responsiveness. You have to look for cardiac output improvement, which is hard to find clinically. So that's the reason I say at the bedside, what you can do best for your patient is there improvement in your flow parameters, that is your perfusion, your pulse pressure, your CFT, and your heart rate, if they're getting better or not, and of course your blood pressure. If not, you'll have to stop fluids. Otherwise, if you have a cardiac output monitoring or echo, you can look for fluid responsiveness and continue fluid bolus. So this is all about fluids. Let's see what to do with the vasoactive agents. So as I said earlier, cold shock, if a patient present in cold peripheries, tachycardia, hypotension, and prolonged CFT, we know that patient is in like high SVR or vascular tone is high. And if the patient has bounding pulses, flash cap refill with tachycardia, then we know that he may have low vasomotor tone and low SVRI. So what we found in some patients were even patients who presented in very cold shock, like cold clammy skin, prolonged CFT, when we put an arterial line, we found wide pulse pressure. So it's not that simple that, my patient has, cold shock. It may be severe myocardial dysfunction. It might not be all the time. Sometimes we find even in cold shock, who have cold clammy peripheries, the arterial pressure, diastolic pressure was very low. So how do you know patient has vasodilatory shock? If the diastolic pressures are, if the systolic pressures are less, diastolic pressures are 50% of systolic pressure. Say, for example, a systolic pressure is 100, and if the diastole, 50% of 100 is 50. So if the diastoles are less than 50%, that means a patient is vasodilatory shock. And of course, it will be associated with your cold, your bounding pulses and flash refill. So sometimes, most of the times, it is vasodilatory shock has warm bounding pulses, whereas the vasoconstrictive or high vasomotor tone can have cold peripheries. But yes, in some patients, because of severe vasodilatation, there can be relative hypovolemia and they can be cold. So you'll have to look at the arterial BP in these patients, which will actually classify where the patient falls. So if you have arterial BP, yes, fine. Otherwise, you can use any of the cardiac output monitoring or even your echo, which will tell your vasomotor tone. So relative hypovolemia is an important contributing factor for hypovolemia in distributive shock. So as I said earlier, in vasodilatory shock, there is fluid distributed wrongly, mal-distributed. So it's all pooled in the venous vessels. Venous capacitance is high and the fluid is accumulated there. So there's no point in giving more fluid in these patients who have vasodilatory shock. Okay, so a pressor is something much more important. Some drugs, any drug such as norepinephrine. So norepinephrine increases your SVR, it squeezes your capacitance vessels and increases your preload and volume venous return to the heart. So apart from that, it increases your blood pressure, predominantly your diastolic pressure. And remember, it has a mild inotropy 1 plus beta effect as well. So it is a mild inotrope as well. So norepinephrine is the best choice if a patient has a vasodilatory shock after the initial 10 or 20 ml per kilo fluid bolus, because it improves the venous return, it improves your blood pressure, and it also has a mild beta-1 activity. So this is what we studied to evidence for this, that norepi is better. We found, we did study in septic shock after the initial 10 to 20 ml for fluid bolus. We started some patients early norepinephrine, and in some patient we followed the previous ACCM guidelines, and the baseline demographics were same in both the patients. There was no big difference. However, we saw the fluid requirement was much less in patients with norepic group when compared to the who followed the guidelines, and your ICU days was much less. So although there was no difference in mortality and any other thing, but the stay in ICU and the fluid requirement and of course the mechanical need for ventilation was very less in those patients who we started early norepinephrine. So it's very important to know the physiological part, what is the problem with your patient, rather than randomly giving drugs like fluids or massive doses of inotropes. So early low dose vasoactives are better than large volume fluid boluses. There is good evidence in adults and pediatric literature as well. And there is evolving pediatric literature, I can say. It results in a sustained hemodynamic improvement and the decreased need for ICU support. So the compelling physiological rationale, especially in developing countries, this is what is important. So norepinephrine in vasodilatory shock, I think it's made for each other. As I explained earlier, how it improves everything. It treats the underlying physiological problems. So pressors are important in vasodilatory shock. So another important thing I want to bring, to you all is the common pitfall. We keep on increasing. Suppose we have a patient with hypotension, it's easiest, you start some norepinephrine, is no response, keep increasing the dose. So we generally start at 0.05 and go maybe up to 0.1, and the patient continues to have hypotension. We increase either to 0.2, 0.3 to 5.3, and then we start adding epinephrine and then vasopressin. I think it's very important to know, don't just keep increasing the inotrope, you figure out what's the problem. So what I'm trying to say is, don't keep increasing the drugs, because that drug itself can cause more problems. It may increase your vasomotor tone and make your cold, clammy skin. Renal perfusion may decrease and urine output may decrease. So you don't know whether the disease process is not addressed adequately or your drug is causing problems. So whenever you start a drug, say for example, you started norepinephrine of 0.05 or 0.1 or even up to 0.15, and you look for the response. Is my patient getting better or not? If he's better, yes, continue the same. If he's not getting better, you may be causing more cardiac dysfunction, because it increases the SVR. So that may cause cardiac dysfunction and may worsen the shock. So whenever you start a drug, see what is the effect of drug. Is he improving, not improving? If he's not improving, yes, what is the problem? Does he need more pressor? Does he need more inotrope, or does he need fluid? So this is how, at every step you start any drug, you'll have to look for the response to treatment, which is much more important rather than increasing your drugs, keep increasing randomly any pressor or inotrope. So we start multiple drugs, sometimes 2 or 3, without knowing what it is. That itself can cause cardiac dysfunction, including diastolic dysfunction and hypoperfusion to organs, more often in kidneys. Always use the lowest acceptable blood pressures. So there are several studies coming up that low BP acceptable target is sufficient. Maybe so if the patient has higher ICP or intracranial pressure, you may need little higher blood pressures. So catecholamines are not that safe. They can cause sympathetic adrenergic stimulation and cause organ dysfunction. Most of the patient responds well to 0.1, maybe up to 0.2. The toxicity is less. Beyond that, you'll have to be extremely cautious in increasing. If the patient needs more, make sure, am I giving the right drug? Am I giving the right dose? Is there anything I have to add, any inotrope, or should I give some fluids and see? So this is how you'll have to go about in managing these kind of complex children who are in shock persistent despite your pressors. So Best to start with the low dose and keep increasing. As I said earlier, while you're increasing the dose or if there's no response, if you find evidence of cardiac dysfunction, if you have an echo, well and good, you can start inotrope like epinephrine. If you don't have an echo and a patient on norepinephrine, if you have tachycardia, worsening distress, falling blood pressure, you can safely add epinephrine. So because there could be myocardial dysfunction. So epinephrine would be better. So again, what dose of epinephrine will go? You start with low dose 0.05, keep increasing to 0.1 and look for titrate the therapy subsequently. So low dose norepi and followed by epinephrine in suspected, worsening shock or persistent shock. Myocardial dysfunction has to be thought of simply because they may have underlying myocardial dysfunction or your pressor norepinephrine would per se would have caused cardiac dysfunction by increasing the SVR. So this is again the same thing, which is repetition. Start at one dose of 0.05. Most of the times, norepi works best in septic shock because of the underlying physiology. As I said earlier, if you find there is evidence of myocardial dysfunction, it may get unmasked. Patient may have cardiac dysfunction in septic shock. Because of the vasodilatation, it may not manifest. The moment you start norepinephrine, it can, because of the increased SVR, it can unmask the underlying cardiac dysfunction. That's when you'll have to add an inotrope such as dobutamine or epinephrine. So you can increase the dose of epinephrine from 0.1 up to 0.2. Again, carefully monitor heart rate, pulse, and any worsening acidosis or is getting better. So if he doesn't improve with these two agents, say norepi and epi, then you'll have to again look for the heart. At this point, I think it's very hard to do just clinical examination and say, this is what would help. This is the point where I would say you should have some kind of monitoring, especially if you're already on norepi and epinephrine of moderate dose of 0.15 to 0.2. You need some kind of monitoring. Simple clinical examination may not help. It may just say is getting better or not, but what is the problem? It's hard to figure out. That's when echo or cardiac output monitor, both are equally important. So if your patient has, as a persistent shock, you can add a third inotrope, vasopressin, or a dobutamine if you have not added. So this is how you titrate inotropes and pressors in septic shock. Of course, simultaneously, you'll have to look for the source control if the shock is not getting better and address the source control, see if your antibiotics are appropriate or not, and consider stress dose steroids when you're on pressors. At least when you start the second inotrope, better to start stress dose steroids. So coming to subsequent treatment, so once things are getting better, you can start weaning that. If you're 6 hours, you stabilize the patient. If things are getting better, you can start weaning slowly. Suppose if there is cardiac dysfunction, what do you start? You're already on a epinephrine of 0.15 and maybe a low dose norepi. Will you consider milrinone at this point? So immediately in the first 24 to 48 hours, or at least first 24 hours, the cardiovascular physiology is evolving. There can be underlying vasodilatory shock still persistent. So remember, if you start too early within the first few hours of shock, milrinone, it can cause hypotension because it is a vasodilatory drug and it has longer half-life. So I think under these conditions, dobutamine would be a better idea for an inotrope and vasodilate as an inotrope and vasodilatory agent rather than milrinone. Subsequently, in the next 24 hours, you can consider milrinone for cardiac dysfunction. So in acute phase, if you have cardiogenic shock or severe cardiac dysfunction in clinical examination or your echo, you can straight away start epinephrine and add second agent like norepinephrine and dobutamine, and even vasopressor to some extent you may need in some patients. Whereas if you have a pure vasodilatory shock, you can start with norepinephrine first, titrate the doses up and monitor for any underlying cardiac dysfunction, evolving cardiac dysfunction or unmasking of cardiac dysfunction, or whether the patient needs more pressors. So if he needs more pressors, you can add vasopressin. If there is suspicious of cardiac dysfunction, you can add epinephrine. So remember, in the first 24 hours, dobutamine, you can play around with drugs like norepi, epinephrine, vasopressin and dobutamine. In the immediate 24 hours, be cautious in using milrinone simply because it has longer half-life. The hypotension may persist. If it happens, so you can increase the dose of vasopressors in these patients. But again, it's be cautious because any pressor can worsen your cardiac dysfunction. So what is a pathway? So let's collate everything now. Fluid bolus 10+10. Watch for response. If the shock persists, clinical examination, what's happening? Is my patient improving? Is the pulse pressure improving? Is the tachypnea worsening? Is my tachypnea improving? Or if you have echo, look at the function, what's happening, and accordingly you can treat. So as I said earlier, if a patient has vasodilatory shock, if the diastolic pressures are half the systolic, then think of vasodilatory shock and you can start a pressor after fluid bolus. If the pressors like norepi, if there's no response, you can add vasopressin. Consider additional fluid if required in these patients. So if the SVR is normal, or if your diastolic pressures are high, if your CFT is prolonged, or if your cold clammy peripheries, think of underlying cardiac dysfunction and you can add straight away epinephrine or dobutamine. So now having come to, so we know now how to recognize when to start fluids, when to stop, what inotropes to choose, how to increase. Next is monitoring. So during the course of this talk, I have covered what to monitor while the patients are being, you're on therapy, either fluids or inotropes, but it's important that you at every step you have to monitor these parameters. What's happening to the blood pressure? Is my MAP improving? Is the diastolic pressure improving with my pressor? Is it what's happening to the pulse pressure? Next important thing is the flow parameters. Flow as in cardiac output. If you have a cardiac output, you'll have to see with my stroke volume improving with the fluid bolus or inotropes. If you don't have a cardiac output monitor, you can look at the extremity perfusion, cap refill, pulse volume, and organ perfusion. Organ perfusion, I mean here, urine output and sensorium. And important thing is, during your therapy, is my patient worsening? Is there any features of congestion? That is called filling. So monitor for pressure, monitor for flow, and your filling. So the filling, I think what you can do is while your patient is on inotropes, fluids, as I said earlier, when you're giving fluid bolus, if there's any organ dysfunction, like mainly lung, if there's worsening dysfunction, you can see worsening tachypnea, right? So that's when you have to stop. Suppose if a patient is on pressor, say norepinephrine, or you're increasing the dose of norepi, or you have added vasopressin, watch for underlying if there is any worsening cardiac dysfunction, where patient may manifest as tachypnea or fall in saturations or hypotension. This is what you have to monitor the patient when they are on pressors or fluids, if you don't have any cardiac output monitoring or echo. So remember always, whenever there's improvement in blood pressure, first thing we see is when the patient, what is the improvement? You have to see the improvement in blood pressure. Okay, with the improvement in blood pressure, there should be improvement in your circulation, peripheral circulation. That is your CFT, pulse volume, and all those. So it's always that when the BP improves, this also should improve. That's called coupling. Okay, sometimes your improvement, there can be improvement in macro circulation, that is the blood pressure and heart rate. But however, the patient will continue to have high lactates and low urine and prolonged cap refill. So this is when it is little more complex. There can be uncoupling of circulation, macro and micro. Again, as I said earlier, you have to look whether is my support. Don't keep increasing the support if the blood pressures are improving and your microcirculatory is not improving. That is, your lactate is still high, urine is less, CFT is still prolonged. Don't just keep increasing your pressors if the blood pressures are normal. This is when you'll have to be a little more complex, or, it's very tricky situation here. You may have to decrease the inotrope or pressor level and see the response. You may need fluid or you may need diuresis. This part is very complex. It's hard to cover here. So something, remember what I'm telling you at this point is, if the blood pressures are good, and if your microcirculation is not good, just don't increase support. Look for other causes and treat, address. Okay. So the basic targets at the bedside, MAP, heart rate, very important. Look for perfusion. This is again, I'm repeating, since it's important that you don't keep increasing the support if the blood pressures are normal. Okay, you'll have to look for other reasons and figure and treat. So another important thing we'll have to look is CVP. Most of us use CVP for fluid resuscitation, right? Which is something being used for years and it's been debunked now. It's not very useful. Why? I'll explain here very quickly. CVP, it's the pressure in the right atrium. So normally heart functions in such a way that right atrial pressures are always low. So there is a good return to the venous return to the right atrium. That is what right atrial pressures or CVP is. So venous return decreases if the right atrial pressures are high. So heart's function mainly is to keep the right atrial pressure as low as possible so that the venous return is high. So if the right heart is not functioning, then the RA pressures will go up and your venous return will decrease. That's when the CVP will increase. So again, it is factored by several things like thoracic pressures, cardiac pressures. It's a very complex, number. It's not that simple that low CVP means you have to give fluid, high CVP. Okay, so CVP is very nuanced thing. If you have a very low CVP, normally CVP in you and me, normal is negative actually, -1, -2 to up to 0 or maximum 3. But if it is going, so a patient who has a very low CVP is safe for fluids, I can say. If the CVP is borderline like 6 to 8 and above, you don't know whether to give fluids or not. If it is high, more than 8, definitely the patient doesn't need fluid bolus. You have to look for other causes. So uses of CVP it is basically a downstream pressures. If the low CVP means if the RA pressure is low, that means venous return is good. It indicates the right ventricular function is good. This patient may be safe for fluids, but we don't know he needs or not. You can safely give fluids. On the other hand, if the CVP is high, it is a stop point that you should not give fluids in this patient. You need to figure out what is the problem. Is the right heart failing? Is there any pericardial tamponade? Or is there intrathoracic pressure high? What is the cause for high CVP? You have to know and treat. Is these patients, you should not default give fluids. If the CVP is low, yes, you can give, but doesn't mean he really needs. You have to see whether he needs really or not and give. But I can say one thing is he may be safe for fluids. So this is the utility of CVP at the bedside. So the concept of CVP reflecting fluid volume status is debunked. It's no more useful as a fluid resuscitation marker. It helps it's important stop point that high CVP, don't give fluids. In fact, these patients may need pressors or inotropes. So few scenarios.
दिवाली की तो सफाई करनी है तो सफाई तो करनी है ना
Sorry.
फाड़ दे कोई
No, continue, please.
Okay, so these are 1 or 2 scenarios I'll just put. Poor skin perfusion, which is cold motile skin with poor CRT. So inadequate perfusion, as I said earlier, will not benefit from more and more fluids on more and more inotropes. Look for the cause. There can be uncoupling. So cause of poor perfusion can be BP is normal but poor macro-micro disconnect. So be extremely cautious in aggressively increasing the supports in these patients. Remember few things in early sepsis with hypovolemia. Hypovolemia, as I said, can mask the underlying hemodynamic hyperdynamic profile. So you all know that in hypovolemia or in a proper GI losses, diarrheal GI losses, gastroenteritis, you have hypovolemia. As a result, SVR is high and you have a narrow pulse pressure. Similarly, in dengue, where there is capillary leak, there is hypovolemia. So you have narrow pulse pressure and you can have high SVRI and vasoconstrictive shock. So sometimes hypovolemia can mask hyperdynamic profile. That's why we said in our study also, when you give fluid bolus, the underlying vasoconstriction will disappear and patient will develop normal pulse pressure. So fluids can cause vasodilatation. So if you have a patient in septic shock with hypovolemia, you can give fluid safely without any worry. But if you have widening pulse pressure after giving fluid bolus, or if the CFT improves rapidly, or if your pulse pressure improves very well after fluid bolus, think of underlying septic shock rather than pure hypovolemia. So in these cases, you'll have to treat like septic shock, which I explained earlier. Early sepsis with vasoconstriction. So some patients will have excessive like cold peripheries, cold clammy up to the knee. There you think of cardiac dysfunction immediately, do an echo, and you can start on epinephrine, and you have to titrate or decrease your doses of pressors like norepi and vasopressin. Sometimes in patients with very late sepsis, they can have low cardiac output, very bad cardiac dysfunction. So again, in these patients, you may need 2 or 3 inotropes like epinephrine or dobutamine. Sometimes they may need vasopressin and norepinephrine as well, even if they have cardiac dysfunction, simply because these 2 drugs may not be sufficient. And you may need higher supports or like ECMO and so on, if there is no response to your inotrope. So what is the emerging theme? Always you have to, the rush is to normalize in first 6 hours is being questioned. Don't keep on filling with fluid boluses. Always less is more. Do gently. Always monitor the targets when you're giving fluids or inotropes. Accept lower targets always. Just like, blood target of hemoglobin is 7. So BP also accept BP, whatever is good for the patient. There's no one good BP for each patient. It may differ. So BP is borderline or getting better with the good urine output, good skin perfusion, good mentation, good urine. You can stop the inotropes at that point. Don't keep escalating simply because BP is not normal for that age. So you approach a patient holistically rather than just chasing one number. Always less is more, less fluid. Don't give too much inotropes. Appropriate inotropes is required. The more you give, the more problems you create, both with inotropes and pressors. More and more inotropes like epinephrine. We have some patients being referred, for ECMO, saying that patient is on 0.5 of epinephrine and 10 or 15 of dopamine. Most of the units have stopped using dopamine after several studies have shown that it is less beneficial when compared to other drugs like epinephrine. So we have patients referred for ECMO for high dose inotropes. Simply we just dial down the dose of, the inotropes, shock got better. So it was all related to inotropes because lot of chronotherapy, can cause myocardial dysfunction, and high pressors can cause myocardial dysfunction. And of course, diastolic dysfunction is much more with inotropes like epinephrine and dopamine and dobutamine. So if you dial down these drugs, that itself will better. So it's very important that you monitor all patients who are on high supports, whether they really need this high or not. Okay, same with pressors and inotropes. So this is what I covered. So one size does not fit all patients. Shock guidelines, SCCM guidelines give broad view of how to manage if you don't have anything, but every intervention should be monitored and assessed whether I'm doing right or not. Multiple entities should be looked into components, our hemodynamic profile has many things, as I said, volume status, cardiac status, vasomotor stone, all should be assessed while you're treating. So that's what will help rather than simply giving, boluses after boluses and increasing the inotropes. So the 10 commandments, my last slide, my 10 commandments in fluid resuscitation. This is a article published in IP. You can read, is a basic management of septic shock in children. So this is published, I don't know when, this year, I think this year or last year, management of septic shock at the bedside. So hypovolemia is a fluid losing state. It's absolute, which doesn't happen much often in septic shock, but it can happen. In these cases, fluids can be given as per the losses. Hypervolemia in septic shock. Hypovolemia in septic, sorry, this is hypo, not hyper. Hypovolemia in septic shock is relative. As I said, there is maldistribution of fluid. Fluid boluses should increase cardiac output and improve perfusion. If you always watch for, if it doesn't so, then it may be dangerous. That, as we showed in our study, the response to fluid bolus can be variable. Sometimes it can improve cardiac output, sometimes it may not. Important is watch for blood pressure. If it is falling, diastolic or blood map is falling, you'll have to stop, because not all patients respond similar way to any fluid bolus. So static test for fluid response is not much useful. You can use dynamic test like, pulse pressure variation, which is all beyond for discussion today. Always know the limitations of fluid responsiveness. There are several factors, as I said earlier. A normal patient can have a septic shock patient can have a low, can be fluid responsive, but doesn't mean he needs fluid. You can try, he's safe for fluids. Fluid overload versus intolerance. So suppose a patient, is suspicious of myocardial dysfunction. or if you have a high CVP, or if you have IBC bulky, or if he has a cardiac dysfunction on B lines on lung, be careful, don't give any fluid bolus in these patients. Always a restrictive fluid bolus with early vasoactive drugs are beneficial. So always look for flow, that is perfusion, cap, refill, and urine, and look for perfusion parameters. Look for the tone, what is the pulse pressure, MAP, and diastolic blood pressure, and look for filling. Is my patient tolerating fluids or not? Is he in congestion or is he safe for fluids? So currently, you constantly will have to balance all the three aspects of cardiovascular tool. Use whatever you're familiar with. Due to some extent, clinical examination is useful. Beyond that, it will be very difficult. You need some kind of tool, at least an echo. Always accept low normal targets. Discontinue what is not working.
Wow. Dr. Rajeshwari, it was very nice.
Okay.
And you have covered almost everything. So I'll just, because the number of questions,
Okay.
I'll just ask the questions. So Dr. Juma, are you there?
Yes.
Perfect. Dr. Basura, sir? Okay. So the first question that was asked in the poll was, this is to you, Dr. Juma. So if a patient is in hypotensive pediatric septic shock, so the fluid bolus, because the people are very much confused, it has to be given over 5 minutes, 10 minutes, 15 minutes, or 20 minutes. We want a clear answer regarding this.
There are no clear studies comparing exactly 10 minutes versus 20 minutes for a hypotensive shock. But if you see what the studies that we have done or the literature which is available, typically in hypotensive shock, we advocate giving the fluid bolus as fast as possible. So that's a decompensated state, and hypotensive shock has a mortality more than 50%. So this is a given, and it is one of the worst parameters that a patient can present with. So we will not delay it here, and we'll advocate giving it as fast as possible, maybe within 10 minutes, and anywhere between 10 to 20 minutes should be okay. But if you ask me personally, we would like to give it within 5 to 10 minutes, because as I told you that the risks are too high.
So there are many guidelines which say 10 minutes, which say 20 minutes. So we'll go with you. We'll say to be given as fast as possible. Within 10 to 15 minutes is preferable.
Yes.
There's a question regarding hydrocortisone in septic shock. So they're asking what is the dose of hydrocortisone and which dose do you recommend? Because there are many doses in the various guidelines. So which dose do you recommend?
I think we should go with the what the Surviving Sepsis Campaign guideline, the ACCM 2017, recommends 100 mg per meter square. That's what we typically use. The recent guidelines, they haven't specified any particular dose, but what we have from the 2017 guidelines is what we have been using typically, the 100 mg per meter square.
So physiological dose is 12.5, so maybe four times or 5 times that. So
yeah,
we accept that.
I think we can ask Dr. Rajeshwari also. Rajeshwari may be also able to give input for this, because
Dr. Rajeshwari, what dose do you use in your unit?
We generally use 1 to 2 mg per kilo, because
that means 2 and 50 mg per
2
meter
mg
square.
per day.
Okay. So we can use anywhere between 2 to 4 because there's a confusion regarding the dose. So it's better that we clarify it. Okay. So this question again to Dr. Juma only. So child is not in a frank hypotensive shock. So as per the latest surviving sepsis guideline, which says that if the child is having no hypotension, but with abnormal perfusion, you will not give a bolus. So what is your take on that?
Yeah, I would not, if the pulse volume is normal, there's just tachycardia because of high fever, and there's the blood pressures are fine, I would not go ahead with a bolus in this patient, because pulse volume is one of the most specific and sensitive markers of, clinical markers of the circulatory status. So I would go with giving only maintenance fluids in this patient, unless we have more than 2 clinical signs which would suggest, compromised peripheral perfusion.
Perfect. So point is well taken. Now I'll go back to Rajeshwari. So we want a clear answer, because you don't believe in warm and cold septic shock without an arterial line. So once you're managing a state in pediatric septic shock, which would be your first inotrope of choice?
So if you're not sure what type of shock it is, norepinephrine would be a best choice, because most of the septic shocks have vasodilatory shock, and as I said, it has a mild inotrope as well. Okay, and if you're during the process, during the course of infusion, if you find that patient is not responding or worsening, you can add epinephrine.
So many of the guidelines, Dr. Rajeshwari, still, though it is a 2017 one, say preferably epinephrine. So do you agree with that?
See, that's what I've been telling. If you find a patient is bounding pulses warm, the dose of epinephrine 0.05 up to 0.1 is a vasodilator. Beyond that, it becomes a pressor, right? So, but the tachycardia worsens with higher dose, So that's why I say that norepi, any low dose 0.05 or norepi or epi, I would prefer norepi first. Even if there is
And do you believe in this guideline, warm and cold shock without an arterial line?
Yeah, this is important, but only thing is it's vasodilatory. It's called vasodilatory and vasoconstrictive, which is important because this is when you decide if you have right side things, you can start epinephrine safely. Whereas on the left side warm, you can start norepi. It is important.
So I'll ask the same question to Dr. Juma. Do you agree with this?
Yeah, so again, this is a controversy, but I would like to go with the guidelines, because, the lot of discussion and lot of literature would have been reviewed, and then we make these guidelines, and some of us are part of these guidelines. So for children, I think it would be, we should go ahead, we should follow the guidelines which have been given to us and start epinephrine, because Rajeshwari ma'am, as per your own studies, we cannot differentiate between warm shock and cold shock, and that's what we do not know what is the underlying pathophysiology in a particular patient. So in that patient, typically, so that's why we suggest that you start with the first line agent, that's the epinephrine. I am sure there are a couple of trials which have been done after that, and maybe the next guidelines will reflect the latest evidence, which will take all of these trials into account, and we can then weigh whether norepi is good as a first line agent, or epi is good as a first line agent. But till then, with so many experts, so much of literature being reviewed, and a guideline which is good, which is good for our clinical practice, and we have been doing well with this. I think the first line, we cannot change at this point to norepi, unless we have weighed all the evidence, and then put that into perspective, and then the guideline changes and says that okay, you use norepi as the first line, and then you add other agents. So
my only point is, you're right, this is a guideline which is important, which has been collated from several things. But the thing is, suppose if you, what I'm saying, I'm not saying it's wrong to start epinephrine in cold shock and, norepi in warm shock. It's perfect. When you're going to doses like 0.3, it's very high. I think at some point, somewhere between 1.5 to 2, you need to look into the underlying problem rather than escalating, simply because you may be worsening things. So it's very, norm, or it's, everyone who don't have access to anything can straight away use epi for cold and norepi for warm. But be cautious when you're increasing the doses, because these are pretty high doses, I feel, at least norepi or even inotrope,
So Rajeshwari, there's a question also, that would you like to escalate the first inotrope to the maximum dose and then start the second, and or when do you start the second? So that again will answer and clear the controversy. What is your take on that, Dr. Rajeshwari?
So as per the guidelines, they say up to 0.3. So I think at some point at 0.2 onwards, you should be little more worrying, jittery. Is it okay to increase, or why is the shock not getting better? Is it my dose inappropriate or inadequate? That is what you look for. Suppose if you have cardiac dysfunction or patient on nor-epi, you can straight away start epinephrine. Suppose if a patient is on 0.2 of epinephrine and is not getting better, you may go to 0.3, or you may need another drug like norepi or vaso. So it's very hard, I think at 0.2 you should be a little more cautious, simply because it's a very hard, tough decision to make,
I
it's
know. I know
clinical
it's a very
decision.
dynamic state. We cannot
Yeah,
give a static
yeah,
answer to
yeah,
a dynamic
exactly.
state.
Exactly.
So, coming on to the next one, you told less is more. So, Dr. Juma, do you agree with this map targeting, that we should target a map which is only 5th and not the 50th centile?
Yeah, in this regard also, Dr. Rajeshwari has already highlighted that, less is more. Yes, I agree. And a target map of fifth centile is perfectly fine when we start resuscitating these patients. But we also have to keep in mind if a child has raised ICP, like she has highlighted. And in such a case, we would want to keep a higher target, say at 50th centile. So depending on your patient and the underlying, disease, I think we will have to individualize the map targets.
Correct. So this is a very Baswaraj sir, are you there? No. Okay, Baswaraj. So again to Dr. Chuma, which vasoactive agents can be started through a peripheral line? So many of the people are saying that sometimes we don't start because we need a central line. So is it a true notion?
No, I think like we advocate in PALS that any drug which can be given through peripheral, we give it through, even you put in an intraosseous line, we would give dopamine, dobutamine, epinephrine could be started at low doses. But definitely these children, when they are in the ICU, we would have a central line in place. We would definitely prefer giving all inotropes and vasoactive drugs through the central line. So there's no doubt about that. But short of that, yes, as per the guidelines also, they say that you can start, epinephrine, dopa, dobuta through a peripheral line. And of course, as you keep escalating, you have to think of every opportunity to start and to insert a central line in these patients.
Right.
But
So,
I
so
think ask,
I
we can have all of your opinions for this.
I ask you only, after how many bolus of fluid would you start a inotrope agent through a peripheral line? So magic bolus fluid, 1 bolus, 2 bolus, 3 bolus,
No,
or
again,
with the first bolus.
yeah, this is also that now we are not, whenever we are having a child with shock, I think we should have two peripheral lines in place right away. And we cannot just wait that we'll give bolus through we'll give first one bolus, two bolus, and then start, a vasoactive agent. So if we need to start maybe with the first bolus or the second bolus itself, but typically we would give one bolus, see the response, and also see the physiology of the patient, and then decide whether we have to give a second bolus and then start the vasoactive drug, or do we start the second bolus, and with that we also parallelly start the vasoactive agent. So typically one bolus, yes, I agree that we would go ahead with one bolus. The first bolus would be without any inotropes, but the second bolus, definitely before we give the second bolus, we can always weigh that whether we should give bolus plus the vasoactive agent or a bolus itself. That will depend on the patient's fluid tolerance, fluid responsiveness, and all those things have to be seen after the first bolus.
Correct. So again, one more question of Dr. Juma only. In that obese child, would you give a actual body weight fluid bolus, or would you say you'll do a ideal body weight and then give a fluid bolus?
Yeah, I think we should go ahead with the ideal body weight. That is what is the ideal. But in an emergency setting, and if we do not have, trained people to calculate the ideal body weight, the first thing that is taken is the actual body weight. So giving the first bolus with an actual body weight in a peripheral setting is fine, is okay. But I think we can, the panelists also could comment.
Correct. So this is to Dr. Rajeshwari. There are many questions in the Q&A. So if a child is in shock with wide pulse pressure, nor-epi or epi? One line answer.
Sorry, white pulse pressure with
Shock,
nor-epi.
nor-epi. So the next question is basically for the icon monitors in shock management. Do you use it?
Yes.
That
The trend is
so-
important, not this absolute single number trend. The first number, whatever is displayed, you need to see the trend. Every parameter trend is important.
So somebody is saying dobutamine in catecholamine resistant shock. Is it not contraindicated in hypotension? Dobutamine in hypotension.
So if there is,
Rajeshwari.
yeah, dobutamine, like if the patient has hypotension and if you think there is cardiac dysfunction, dobutamine will help. On the contrary, it's a myth that dobutamine should not be given in hypotension. But if the patient has cardiac dysfunction, it has inotropy and it may improve the blood
So
pressures.
I'll ask if a patient has myocarditis, you have to
Yes.
choose between the two, myocarditis with CCF. You have to choose between the two, nor-epi plus dobutamine or alone epinephrine. Which one would you choose?
If epinephrine,
So in a myocarditis, you would not like to choose dobutamine plus norepinephrine.
I mean, I'm not saying yes or no, this or that. The first choice would be that. If there's no response, I would add some other drug.
Dr. Juma, do you agree with that, or you want to give a dobutamine or epi or just epi in a myocarditis, not a septic child, but a myocarditis?
Yeah, I got it. So typically we avoid dobutamine because it has we have seen lot of arrhythmias. So don't that's our clinical experience. So we are more comfortable giving milrinone as a combination with norepi.
Okay, so next question is maximum dose of noradrenaline that you use, Dr. Rajeshwari.
I think it's again unit based. We don't go beyond 0.25 to 0.3.
0.3. Dr. Juma?
No, we do go up to 1 sometimes. We max out on the doses of norepi and even
Okay, perfect. So how many doses of steroid do you advise, Dr. Juma, in catecholamine resistant shock? 1 dose, BD dose, 3 days, 2 days?
That's already, I think we have already discussed that, Dr. Maninder, that 100
Right.
per meter square per day in 4 doses, divided in 4 doses.
So the many questions. Okay, to Dr. Rajeshwari, this passive leg raising test. Honestly, are you doing it in your unit, and is it doable, feasible?
It is not doable. We are not doing.
There's so many questions. For microcirculation, which parameter do you use?
I think the capillary refill, lactate, and pulse volume.
Perfect. I think so. We have answered all the questions. There's actually more. I'm avoiding them because it's already 10:15. So, Dr. Meena, are you there?
Yeah, I'm here. I think Dr. Dinesh. Anyway, I'm putting. Thanks to Dr. Rajeshwari for wonderful versatile talk, and I think in your presentation you cover the lot of the important things, or audience might be get the more able to make the more clear
Dr.
concept
Meena.
regarding the how to manage the children's are the shock in the case of the sepsis. And thanks to my colleague Dr. Juma Shankar for valuable inputs, and our past president Dr. Basav Raja sir. As usual, evergreen, Delhi ka hero, Dr. Maninder. You made the really this program wonderful, and actually I am regularly getting a lot of the feedback from the our participant. This program is highly demanded, and even after complete the 3 classes, we continues getting the lot of the registration still. So that indicate the how this program is famous in our students or practitioners. Thanks a lot, dear Dr. Maninder and entire team. Welcome, Dr. Dinesh. Kindly
Thank you,
put
sir. Good morning.
input.
After a morning walk, we are here in the e-class.
Actually, in the morning, we have the cardiac walk on the occasion of the World Heart Day on 29th. That's why we are slightly late join today's activity. Over to Dr. Maninder.
Dr.
Uh,
Maninder,
sir,
many congratulations for these wonderful sessions. And this is actually for general pediatrics and as well as the intensive care. The first interaction with general pediatrician in the clinic, in hospital emergencies, and then all comes to the intensive care. It's a beautiful presentations from Dr. Rajeshwari, and very important part, fluid management in the sick childs. And it's, I must say, the congratulations to you all guys. You are doing wonderful job, and thank you so much. Now, please.
so I would like to thank both the moderator and the speaker because I had actually asked them very tough questions. They look very simple, but believe me, there are no straight answers for these questions. So from the Dil say thank you to Dr. Rajeshwari for a wonderful presentations. You have covered everything in 1 hour, which is required by the students. You have made it very smooth and physiologically based talk. That is very important. And for Dr. Juma to give us clear guidelines and instructions, because that is very important for students to follow.
And thank you for the ragging.
Thank you. So
Chalo,
with the
great.
blessings of
It's a
Delhi
very
IIP,
complex topic to say yes or no answer, this or that.
correct.
That's how ICU is, any patient management. It's not like mathematics.
Exactly.
True.
And
So with that,
thank
we like to close and thank all of you for sparing the Sunday morning to us. Thank
we
you.
missed you, Maninder, today morning in World Heart Day and a morning walk. But we
I know,
know
sir.
you are also busy. But
Right.
it's awesome.
Thanks, sir.
Awesome.
Sure, sir.
Thank
Okay.
you.
Thank you,
for
Dr. Meena.
Thanks for the
Thank you.
invite.
Bye.
Thank you.
Bye-bye.
Thank you. Thank you.